Hey peeps. So this is a broad overview of gynecologic oncology. I gave this lecture to the medical students here at the University of Utah. It is packed full of information. It's a pretty long lecture because it's trying to go over kind of all the disease sites and the most important things on each one. So go through it yourself. Ask any questions in the comments below. So overview, we'll go over some definitions and concepts that I feel are really important and sometimes are not touched on, and then we'll go through each disease site. We won't talk about any fertility-sparing treatments. Each of these could easily be their own hour lecture, and so bear with me on how much information I tried to squeeze in. And I used a lot of information specifically for medical students. So this is a great overview, but even a good review for some residents who haven't been on onc in a while. So staging versus debulking is a really important concept that I feel like we don't go over in the beginning. So a staging surgery is surgery or imaging to find where the cancer has spread. And that is simply just like mapping how far the cancer has spread. And the more accurate the mapping, the better we can treat and predict outcomes. That's opposed to a debulking, where we already know the cancer has spread. Either we can see it on imaging or we look at it with our eyes, like in this picture. And debulking is removing all visible disease. So we oftentimes will say, this is a staging surgery, or this is a debulking surgery. And that's exactly what these mean. Completely different concepts. And then surgical versus clinical staging. So cervical cancer and vaginal cancer can be staged clinically, and then we stage endometrial cancer and ovarian cancer. We mostly stage them surgically, and we can also stage cervical cancer surgically. And so surgical staging is a formal operation, and then clinical staging uses tools like imaging or cysto or proctoscopy to find kind of where the cancer is. The first disease site that we'll start with is ovarian cancer. Average age 55 to 65. The lifetime risk is 1 in 75. Some risk factors here include family history, genetic mutations like BRCA, nulliparity, can be endometriosis, obesity, or smoking. And then some protective effects here are OCPs, IUDs, a salpingectomy, breastfeeding, and removal of the ovaries. Ovarian cancer is sometimes called a silent disease because we typically catch these at very late stages because the symptoms are non-specific, like bloating or belly pain or early satiety, urinary frequency. And so it's called silent because we don't pick it up, but women do have symptoms. They do. It's just mostly these are like GI, GU in nature and oftentimes written off. And so we'll just kind of go over this. This is a nice picture of an overview of the several types of ovarian cancers. Our most common being epithelial ovarian cancers, but then we also have sex cord-stromal and germ cell tumors. And so this is kind of showing like where each of those come from. And so we'll go over a broad overview of each of these. But I do want to point out here that although it's like pointing to the epithelium, we now think that serous epithelial carcinomas come from the fimbria of the fallopian tubes. And so that just isn't depicted in that picture here, so I wanted to put that. And so we'll go over kind of each of these here, but sometimes pictures are a nice way to organize things in your mind. So the typical workup for an adnexal mass that may be an ovarian cancer is getting some imaging, so an ultrasound or a CT, and then tumor markers. And so these are important. They're markers that can be elevated in ovarian cancer. And we typically will get them hopefully prior to the surgery, and then we can follow them after the surgery. They're not diagnostic though. And so the epithelial markers are CA125, CA99, and CEA. Germ cell tumor markers, AFP, beta-HCG, and then LDH. And then sex cord-stromal tumors are hormonal, so testosterone, estradiol, and inhibin A or B. Mostly B, we'll talk about it. And then getting an image-guided biopsy if at all possible. Not of the ovarian mass. We do not want to biopsy ovarian masses because of the risk of rupture and seeding. we usually are trying to biopsy a lymph node or an enlarged lymph node, concerning lymph node, or an omental cake, something like that. So sometimes we can't do an image-guided biopsy. And so we have some guidance on imaging of concerning features. And so here you can see that a cyst greater than 10 centimeters, ACOG says should be referred to Gyn Onc. I think it really depends on what the cyst looks like. So if it has papillary or solid components, if there's ascites in the belly, if there's high Doppler flow indicating vascularity, all those could be concerning features. But a likely benign cyst is just simple, thin, smooth walls. It can have septations, but benign or malignant. So that one's a challenging one. And no solid components or septations. It looks like a very simple cyst is going to be mostly benign. Okay, so we mentioned the tumor markers earlier. Epithelial tumor markers, CA125, so it's cancer antigen 125. This is derived from the peritoneum, and so this can be elevated in any conditions that irritate or inflame the peritoneum. Can even be elevated in some like lung pathologies as well. CEA is carcinoembryonic antigen. This is present in the colon, but it can also be present in mucinous ovarian tumors. And then CA19-9 or cancer antigen 19-9, which can also be elevated in mucinous tumors, sometimes in endometriosis, sometimes in dermoids. And so, like we said, we use these oftentimes in surveillance, like after surgery, once we know the diagnosis. They can be helpful before surgery to kind of like risk stratify, but they're not perfect. Germ cell tumor markers derived from primordial cells or cells that eventually become sperm and eggs. These are typically germ cell tumors arise in younger women. And so AFP, you'll see this in yolk sac and embryonal tumors. LDH for dysgerminoma, I like to remember there's a D and a D. And then beta HCG can be associated with choriocarcinoma, embryonal dysgerminoma sometimes. So these are really nice to memorize. And lastly, we have sex cord-stromal tumors. The sex cord cells, Sertoli, granulosa, and Leydig, and then the stromal cells, fibroblasts, and theca cells. Average age of these tumors is around 50, and they can be hormone secreting, and they're often solid. So if you see a solid mass, you're going to want to think about this. Granulosa cell tumors are often estrogen secreting, and this can stimulate the uterine lining. And so you have to sample the uterus if you are preserving the uterus in these patients. The tumor marker for these is inhibins, more specifically inhibin B, but oftentimes the test comes together, A and B. And then Sertoli Leydig cells can be testosterone secreting. And here's the staging just for your reference. So treatment of ovarian cancer. We won't go into the nitty-gritty of the treatment, but surgery is a key component. And the goal of surgery, like we talked about, staging versus debulking, depending on how much disease is there. Up front, we call it a primary debulking, and then the alternative is if you do not feel like you can resect all of the disease up front, they can get chemotherapy. We call it neoadjuvant chemotherapy. And then they'll get like 3 cycles, and then you attempt an interval debulking at that time. And this is just another picture of the different epithelial ovarian cancers and some of their characteristics. Clear cell and endometrioid are both endometriosis related. I think that's a pretty high yield concept. And so that's good to know in patients who have endometriosis. Germ cell tumors, like we said, often present at a very young age, almost always unilateral and almost always stage 1. And we talked about some of the different types here. A teratoma or dermoid is a benign tumor, which can have malignant transformation in about 1% to 2%, and usually it's a squamous cell carcinoma from that ectoderm. You can also have an immature teratoma, and this is malignant. 20% of germ cell tumors comprise immature teratomas, and these are often in younger ages. This is a picture of a teratoma with hair, with fat. can have teeth in there. And then a typical buzzword for a teratoma benign is a Rokitansky nodule. Dysgerminomas are more common. 50% of malignant germ cell tumors, oftentimes occurring young. 5% can be associated with Swyer syndrome. They often present at stage 1. They can be bilateral in 15 to 25% of the time. And they can have this is an important note for probably residents, but they can have lymph node mets. So if you do have a dysgerminoma on frozen, then you do have to do a lymph node dissection. And remember, like we said, LDH is the tumor marker most specific for dysgerminoma. Remember that D in dysgerminoma, D in LDH. And then the last of the germ cells we'll go over are the endodermal sinus tumor or the yolk sac tumor. This is a pretty aggressive tumor and sometimes can present with spontaneous rupture. The marker for this is AFP. So treatment, a combination of surgery plus minus chemotherapy. In dysgerminomas and grade 1 immature teratomas, you don't need any adjuvant chemotherapy. Everything else requires chemotherapy with BEP, which is bleomycin, etoposide, and cisplatin. In most cases, you don't need to do a lymph node dissection or an omentectomy unless a dysgerminoma. And recently I was reading about also doing them in immature teratomas. The literature is different in Gyn Onc versus pediatrics. So I think it's going to be, if you have a case like this, you need to go back and look at the literature. But you should encourage fertility preservation, especially in these young patients. Hysterectomy, BSO does not necessarily change the outcome. A lot of the times, these are very chemosensitive. And so we do a lot of fertility sparing surgery for these germ cell tumors. And then sex cord-stromal tumors, also pretty rare, usually diagnosed when stage 1 and unilateral. Granulosa cell tumors, we talked a little bit about. Average age of 50. I think an important point for granulosa cell tumors is these can recur late. And so oftentimes we'll follow these patients for many, many more years than we would in someone with an epithelial ovarian cancer because they can recur 10, 20, 30 years later. These oftentimes can rupture and hemorrhage. That can be their presenting, that can be how they present. And like we said, they produce estrogen. You can have adenocarcinoma. I typically say, 5% cancer, 25% hyperplasia. And we talked about inhibin A and inhibin B, and these patients should have FOXL2 genetic testing. And then lastly, we have sertoli Leydig tumors. These are also pretty rare. They can be hormonally active, like we discussed. Testosterone is usually a marker, and like granulosa cell tumors with FOXL2, we want to be sure that these patients are tested for DICER1 mutations. This is just an example of someone who had a sertoli Leydig tumor and was exhibiting male pattern baldness as a female, so just an interesting viralizing picture. Okay. I think for the sake of time, we won't go over these. I'm obviously going to leave them up, and I can put the answers down in the comments. But go ahead and pause and read them and try to guess. Okay, next we'll go into uterine cancer. And uterine cancer can be broken down into two main categories. Endometrial, which is that inner cavity, the endometrial cavity, and sarcomas, uterine sarcomas, which is a muscle tumor. So endometrial cancer is the fourth most common cancer in American women. It actually is one of the only cancers right now with an increasing incidence. So that is very concerning. And majority of the disease is diagnosed early, and we have a common sign, which is vaginal bleeding. Average age is around 60. Risk factors, a huge one is obesity, chronic anovulation, late menopause, unopposed estrogen use, estrogen secreting tumor like a granulosa cell tumor is more rare, or genetic syndrome like Lynch syndrome. And like we said, presents oftentimes with postmenopausal bleeding, spotting, discharge. And to evaluate, we typically get a transvaginal ultrasound to measure the lining. We want that lining to be less than 4 millimeters, And if it is not, then an endometrial biopsy is indicated. We won't go too much into this slide because the whole subtyping of endometrial cancer is changing. I would say it has changed. And we used to do a type 1 and a type 2, with type 1 being more endometrioid and type 2 being the higher risk cancers like serous, carcinosarc, clear cell. But now we have all this data from the Cancer Genome Atlas, which really kind of opened our eyes to 4 molecular subtypes in endometrial cancer. And you can see them down here, and we'll blow them up on the next slide. And so the subtypes, polymutated, MSI, or hypermutated, copy number low and copy number high, are how we're going to probably be categorizing endometrial cancers in the future. And these really point more to prognosis than the type 1 and type 2 that we had in the past. And so that this is a little bit in depth for our scope right now. It's currently not we're not basing treatment off of it quite yet, although we are with some caveats maybe. And so just stay tuned. Know this is out there. Know that we are shifting away from the type 1, type 2s. These are just some notes. Like we talked about in the beginning, endometrial cancer is typically staged surgically, and this is driven by the mode of spread, usually direct extension or lymphatic spread, and the purpose of staging is to provide prognostic information and to guide adjuvant therapy. Another new thing is that this is the old uterine cancer staging, and now we have an updated endometrial cancer staging. So this is the FIGO 2023 staging. This incorporates histology, which is something new for everyone. And I think we were very hesitant to adopt it in the beginning, but now it is. We have found it to be very helpful. So here it is here. So like we said, we're typically taking these patients to the OR for a staging surgery. That includes total hysterectomy, bilateral salpingo-oophorectomy, and lymph node dissection. We're doing sentinel lymph nodes in endometrial cancer. I actually have an endometrial cancer full lecture up on my YouTube. So if you're interested in more information, I kind of go into more of the details about sentinel nodes and why we do what we do in endometrial cancer. So see that, because that is a more in-depth overview than this. This is about all I'm going to say about staging. And then advanced stage, if we can't operate on them or we do surgery and they end up being an advanced stage, we are doing chemotherapy and immunotherapy most of the time in these patients. And then just a quick blurb on sarcomas, basically so that you know that they're a thing. Here are the different types. I'd say leiomyosarcoma is probably one of the most things we get referrals for, which would be like an enlarging fibroid in a postmenopausal patient. In reality, about 2% of suspected fibroids are leiomyosarcomas. Then we also have low-grade ESS, adenosarcoma, undifferentiated sarcomas, and PComas. Typically, we're really trying to operate on these patients. And then if adjuvant therapy is a combination of chemo and radiation. And once again, we won't go through these questions, but feel free to pause, go through them yourself, and I'll upload the answers later. Okay, gestational trophoblastic disease or gestational trophoblastic neoplasia. So this is an abnormal proliferation of placental tissue. This can be benign or malignant. Sorry about that. The animations, I love them actually. So benign we call gestational trophoblastic disease. Malignant is gestational trophoblastic neoplasia. In the benign categories, we can have hyadidiform moles, complete or partial. And then under the malignant categories, we have invasive moles, choriocarcinomas, placental-site trophoblastic tumors, and epithelioid trophoblastic tumors. And so hyadidiform means grape-like, and it's a defect in fertilization, and the placental villi become edematous, and they form these grape-like structures, like this picture here. So oftentimes GTD can present as a molar pregnancy. This usually is picked up, imagine someone going to the emergency room with vaginal bleeding and a positive pregnancy test, and so they get an ultrasound and it can show something like this. Would be an example of a complete molar pregnancy on ultrasound. or it could look like a partial molar pregnancy and look abnormal, and then that is usually diagnosed on a DNC pathology. And so we'll go over some more signs or symptoms in the next couple slides. And so risk factors, North America, Australia, Europe, 1 in 1,000 pregnancies, Southeast Asia, 2 in 1,000 pregnancies, and then extremes of age is like often a buzzword. So less than 21 or greater than 35. A prior molar pregnancy puts you at an increased risk of another molar pregnancy, but a smaller, not a smaller risk, but still a small risk, but a higher risk than baseline. And then a history of a spontaneous abortion can put you at an increased risk. And then prior ovulation induction can increase the risk of multiples, and then can slightly increase your risk of having a normal fetus and a complete mole. So partial mole is usually a triploid. This occurs when an egg is fertilized by 2 sperm. And so I like to think of partial mole. It has a lot of P's. So fetal parts are present, and then P57 positive on IHC. It can have focal villus edema and focal trophoblastic proliferation. It oftentimes presents as first trimester bleeding. It's often diagnosed as a missed abortion on ultrasound. These are kind of compared to a complete mole, so the uterine size is usually normal or not greater than whatever dating you have. It's oftentimes rare to see any ovarian cysts, oftentimes rare to see any medical comorbidities, which we'll see all of these in a complete mole. And then oftentimes the beta HCG is at a normal level or just not astronomically high like in a complete mole. And then the incidence of postmolar GTN, or the risk of them developing GTN after this, is usually, we say, 5% or less. And then this is all compared to a complete mole. And so complete mole is a diploid, usually an empty egg fertilized by 1 sperm that then duplicates its DNA, or 2 sperm. But the nuclear DNA is 100% paternal. Typically, fetal parts are absent. Remember, in the partial mole, there are fetal parts. There's diffuse villus edema in a complete mole, diffuse trophoblastic proliferation, and P57 negative. And then the clinical presentation of a complete mole is this snowstorm, a grape-like appearance on ultrasound. Usually uterine size is greater than dates. The beta HCG is very high. You can have ovarian cysts in about 15 to 25% of patients. And then because the beta is so high, you can oftentimes see hyperemesis, preeclampsia, or thyroid storm in these very, very early pregnant patients. And then the risk of developing GTN is much higher. Usually I say 20%. So this is just like a clinical scenario that you might get the patient's 10 weeks, but your uterus is kind of up to your umbilicus on your fundal measurement. So this is size greater than dates. And this is just a chart for you all to have that just compares the features a little bit easier to see. Okay, so once you suspect a molar pregnancy, before you're going to the operating room for an evacuation, obviously you're going to get your H&P, you're going to get labs, so beta, a type and screen for sure, and then you're going to get liver, renal, thyroid functions and coags. Remember, we talked about how the thyroid, you can get hyperthyroidism. You're going to have your ultrasound already, hopefully. Chest x-ray is recommended. And then you go to the operating room for section D&E. You're going to want to have uterotonics and your hemorrhage meds available. You don't want to induce these patients. You usually want to do a DNC. And you definitely want to have availability of a blood bank and an ICU because these can bleed. So you want to be prepared. And then hysterectomy is an option for patients who don't want future fertility. There is still a small risk of postmolar GTN, so you still need to follow up, but it is an option. And then after evacuation, don't forget ROGAM if you need, and then send this to pathology and close monitoring of the patient in the post-op period. And then recommending them to be on contraception. The goal to identify GTN after the evacuation of a molar pregnancy is to identify it early. Most of the time you can pick up on this in the first 6 months. And so serial beta HCGs are going to be very important. So after the first 48 hours evacuation, and then every 1 to 2 weeks until negative times 3, and then monthly times 3, and then you can space out to every 6 months. We do recommend continuing contraception because you don't want it to be confused, obviously, if someone does get pregnant during this time period. And so the diagnosis is very important. Plateau of your betas of 4 values over a 3-week period. The beta increases more than 10% on 3 values over a 2-week period, or choriocarcinoma on your pathology. Always remember to rule out a new pregnancy. This is the FIGO staging for GTN. One important thing here that likes to be sometimes tested upon because it's different is lung mets is stage 3. Usually in every other disease it's stage 4, but stage 3 here. And then the WHO prognostic scoring. This is also highly tested upon, so it's here for your reference. And yes, you do need to know the categories because that helps you stratify your treatment. And so you calculate your WHO score. If it's less than 7 or greater than 7, if it's less than 7, single agent chemo. If it's greater than 7, you're going to need combination or multi-agent chemotherapy. We won't go over that in this one. I actually have a GTN lecture as well, so go see that one if you want more in-depth information about this topic. Here are some questions about GTN, GTD, and we're moving on to cervix. I hope everyone is still with me. We only have 20 slides left. Okay, so cervix. We have to start with pre-invasive disease, and we call that CIN, or cervical intraepithelial neoplasia. It's confined within the epithelium, so it hasn't broken through that basement membrane yet. And I really like this picture here because it kind of shows the progression from normal to cancer. And the severity is determined by the proportion of the epithelium showing disordered growth and development. And so like in CIN1, the changes are restricted to the lower 1/3 of the epithelium, CIN2, 2/3, CIN3, more than 2/3. You get the picture. And so pap smear screening, cervical cancer screening is pap smear screening. And the goal is to sample the transformation zone. So I put this picture in here for anybody who doesn't remember what the transformation zone is. And so that's the area where the transformation from the squamous epithelium to the columnar epithelium take place and where dysplasia can typically arise. Pap smears are screening tests. They're not diagnostic. And the ASCCP has some excellent guidelines on pap smears. They have an excellent app you should download. I think it costs like $10 for a lifetime, but it's like well worth it. And so if you have an abnormal pap, you go to the ACCP guidelines and they might tell you that you need a colposcopy, and that is for diagnosis. So pap screening, colposcopy is diagnosis. Oh, that was my pap. And this is my colposcopy. So primary cause of CIN or cervical cancer is HPV 16 or 18. Risk factors are early exposure to HPV, early intercourse, multiple sexual partners, sexually transmitted infections. At least 80% of sexually active individuals will have an HPV infection by the age of 50. Most of the time, people clear it. But other factors that can influence CIN, 100% smoking, immunodeficiency, or immunosuppression. And so we did talk about colposcopy. This is a colposcope here, which will help you to see kind of some of those minute details. And treatment for CIN1 or 2, you can typically observe with repeat PAPs, and then CIN3 is an excisional procedure like a cone or a leap. Cervical cancer is the 4th most common cancer worldwide. PAPs and HPV testing reduce the risk of cancer by 90%. And the HPV vaccine is greater than 99% effective in prevention. And this is so important. And this needs to be shouted to the rooftops. So the most common type of cervical cancer is a squamous cell carcinoma, followed by adenocarcinoma, and then more rare types like gastrointestinal type, small cell melanoma. There are a few other types. The route of METs is often by direct extension, and sometimes we get questions about in utero DES exposure, which is not common anymore, but it increases the risk of a clear cell carcinoma. And then risk factors are the same as CIN, so smoking, history of HPV, immunocompromised state. Symptoms can be itching, pain, bleeding. I'd say one of the most common is postcoital bleeding or bleeding after intercourse. Early disease can oftentimes be asymptomatic, so we've got to get our PAPs to get screening and catch that early disease. You can also have some watery discharge, some pelvic pain, pressure, rectal or urinary tract symptoms. On exam, you may see a friable or very easily bleedy cervical lesion or a mass with invasion in the upper vagina. And then staging, we talked about this can be clinically staged, acceptable tools, an examiner anesthesia, chest x-ray, cysto, we can use MRI and CT scan. The clinically staging was largely due to the fact that this is a leading cause of cancer in developing nations where many diagnostic tools are not available. But now we do have the ability to use some imaging, and we indicate that on our staging. So we put like a little R next to the stage to indicate that it's like radiographic staging. And then 5-year survival rates for stage 1 are excellent, and then if it spreads to stage 4, it's not as good. And so this is just a chart of a general view of the treatment. I think you should get a NCCN login and look at that yourself because there are some nuances here. So I think that overall you can say this is the general treatment, but with a grain of salt. Again, some questions here that you can go over. Pause, go over, because we have one last disease site, and it's vulva. And so this is very similar to cervix, but we'll start with VIN1, which is vulvar intraepithelial neoplasia. Same thing, atypia confined within the epithelium, and same risk factors, HPV 16, 18, immunocompromised smokers. VIN, the most common symptom is itching or irritation in the vulva. The appearance varies. It could be white, red, pigmented, raised flat. Any lesion needs to be biopsied. And VIN, there's 2 pathways. So there's an HPV-mediated pathway, and then there's a chronic inflammation pathway that most often includes like lichen sclerosis. Overall, the treatment for VIN is most often excision. Because you're getting a good sample, you're making sure that there's no underlying invasive carcinoma. You could also laser, though, if you're certain that there is not a carcinoma. And also imiquimod is not FDA approved, but is sometimes used as an option. Most common types, squamous cell carcinoma. You can also have basal cell melanoma, Bartholin sarcoma. Risk factors, smoking, history of cervical cancer, history of HPV, immunocompromised state. We talked about the symptoms. This is surgically staged vulvectomy, which is a removal of the area of concern on the vulva, plus or minus a lymph node dissection based on the stage. So one thing that is very important in vulvar cancer is that lymph node status is the most important for prognosis. So that is why sampling the lymph nodes is really important when indicated. Okay, so we have just a few clinical scenarios here as well. Okay, and so here are my resources. Follow me on Instagram and YouTube. And if you have questions, let me know in the comments. I actually feel like I flew through this lecture. And so if anything was unclear, just let me know. But I think this is a really nice overview of the different disease sites. And if you're just going to go on your Gyn Onc rotation, this would be a really nice thing to listen to the day before. All right, questions in the comments. Thanks.